everyone. I hope everyone is doing well and staying safe this period. I'd like to thank BMJ for inviting me to share Singapore's experience. During SARS, I was actually, like SF, heavily involved at the front lines. I'm an ICU consultant and an anesthetist, and I was responsible for coordinating the ICU responses in SARS Central, which was my hospital. Next slide, please. So some background about the SARS outbreak in Singapore. We had a very brief 3-month outbreak, during which we had 238 cases and 33 deaths, giving us a case fatality rate of about 13.9%. The major characteristic of the outbreak in Singapore was that there was significant healthcare associated transmission. And this affected patients, visitors, family members, and staff. Okay, and predominantly a lot of staff were infected, pretty much the same experience as Hong Kong. And some of the reasons why were the particular clinical features that we face. We had atypical clinical presentations that led to late diagnosis. Our first index case was a super spreader, and she was responsible for a huge cluster in Tan Tock Seng Hospital and spun off several clusters elsewhere. And we had initial suboptimal infection prevention and control processes in place. Next slide, please. I'm going to cover 3 key lessons from the SARS outbreak that I think we have managed to put into our outbreak playbook and continued over these years since SARS outbreak. The first deals with community measures. We know that early isolation and quarantine of cases is a key feature of being able to control any outbreak very, very quickly. And what Singapore did, I had to learn how to do very quickly over just about a period of about a week to 10 days during SARS, was to put in an aggressive contact tracing process. This relied on very broad case definitions for suspects so that we could catch as many people as we could. A whole team and a system behind that gathering data for contact tracing. And coupled with this, all the individuals that we identified as suspect or contacts or infected, we had to quarantine and make sure that these quarantine measures were effective. Could we go back to the previous slide, please, Maddie? Thank you. And so to do that, we had to tweak and enhance our quarantine and surveillance laws so that we could actually hold individuals in quarantine facilities or in their own homes for 10 days or more. Singapore, as you know, is a major travel hub. And so to prevent import and export of infected cases, we had to do what is now almost a routine sort of practice in almost any pandemic in every country, and that is to impose health declarations, travel advisories, and travel restrictions. During those days, we were probably one of the first countries in the world to adapt the use of thermal imaging scanners for mass temperature screenings for travelers arriving at our borders. And we also worked very closely to keep the information flow going about the infected cases to WHO, transport agencies, and other countries. In fact, there was one case where we discovered that one of our doctors went for a conference and fell ill, and we thought that he might have SARS, and so we actually informed the airlines, the country that he was traveling to, and they managed to catch hold of him, in the middle of his journey and quarantine and isolate him in Frankfurt. So that speaks of how, the cross-country collaborations really help not only Singapore, but other countries and the world to contain this infection. We had many, many programs to engage our community. One of the most important ones was to have our entire population participate in health surveillance and reporting of infections. And we felt that this was something that was very, very key because, if sometimes you wait for people to get very, very ill before they present to healthcare, then, we would have lost significant time, and the number of cases that have been exposed to that infected person would have been significantly higher. So we did a lot of programs, including supplying thermometers to individuals and to households, teaching children at schools and workplaces how to monitor temperature and health, and to be familiar with the symptoms of SARS. In addition to that, we engaged all our primary care practitioners to make sure that they were equipped, they had the information about the suspect case definitions, and we had processes in place for them to be able to isolate and transfer patients that were infected. And lastly, the most important measure, I think, for the community is communication to ensure that they have timely and transparent information about what is going on. And this is to prevent misinformation and fake news from circulating. So we had inter-ministry task force briefings on a daily basis, giving very detailed information about the cases and whatever other information was necessary. We also made use of formal and informal channels, multimedia platforms, and because Singapore is a multiracial society, we had to have multilingual communications as well. We tapped on a lot of social networks and even grassroots organizations to help to get this information out to our public so that everyone was aware immediately of what was happening. Next slide, please. Hospitals were a major focus and a battleground for us in Singapore during SARS. There were very key changes in our infection control practices. I think much like Hong Kong, we experienced, we found that we had several gaps in our infection prevention and control measures. So post-SARS, you will see that all our institutions, all our healthcare institutions have screening and triaging stations at entry points. And this is not just only for, conditions such as SARS or COVID, but really, any and every infectious disease, epidemic or pandemic that comes around, be it H1N1, MERS, monkeypox, we will activate all of these screening and triaging stations. Our healthcare institutions, we have plans every time the button is hit to zone our hospitals into different areas so that we can segregate patient groups, those that are truly infected, those that are suspect, and patients that are clean, so that we make sure that there is no mixing of patients and reduce the possibility of transmission. Because we knew that visitors are actually a risk, and so we have instituted in all our hospitals visitor registration systems. We started off with manual ones, but now we have moved on to electronic systems for registration, so that every single visitor who visits someone in the hospital needs to register, and we keep that information for a defined period of time in case we need to do contact tracing. And finally, we've also increased surveillance of infections, including things such as community-acquired pneumonias in the hospital, so that we can detect and pick up clusters of infections in patients very, very quickly. SF has also mentioned some staff measures, and you'll find that a lot of the measures that we have employed in Singapore are similar. We have had an ongoing staff temperature and sick leave surveillance system within our hospital. So, anytime I fall sick and I need to submit an MC, it goes into the system and it tracks, so that if there's a cluster within the healthcare staff or the healthcare team, then we can also actually pick it up very quickly. We have got very, very significant increase in the amount of infection prevention control training, not only at orientation, but on an ongoing basis, and very strict enforcement of personal protective equipment usage. We have, in our staff deployment plans during pandemic, we do have plans of how we restrict staff movement and deployments and move them into split teams, so that in case one team goes down with an infection, we still have sufficient resources to be able to deliver care appropriately. And of course, we've also have ongoing peer support and staff vaccination programs these years. The third area of hospital measures lies in strengthening our, previous slide please, Maddie, lies in our strengthening of our infrastructure and our infection prevention capabilities. There was a shortage of isolation beds at the start of SARS, and this required us to quickly move into a conversion mode where we had to convert single rooms and cubicles into isolation facilities overnight. When the number of cases went up, we actually had to take one large acute hospital, 1,000-bedded acute hospital, Tan Nok Seng, offline from acute care and convert that into a total isolation facility. So however, since that time, we've actually increased the capacity and the number of isolation beds. First, building a temporary facility using one of our unused facilities, giving us about 32 general beds and 18 ICU beds and one operating theater in a CDC2 facility. And last year, we opened a 14-story purpose-built National Communicable Infectious Disease facility just in time for us to receive monkeypox and also just in time for COVID this year. Our outbreak playbook requires us to keep, to predict and to have a stockpile of between 4 to 6 months of PPE, equipment, medications, and even things like lab reagents that we need to use to run our lab test kits. Our outbreak playbook also, defines the modified processes for support services down to areas that you would normally not think about during a pandemic, such as kitchen, how your linen and laundry are being processed, your transport services, and even security personnel. This outbreak playbook of ours is regularly updated as new diseases come on board, such as Ebola and MERS, and we actually have regular pandemic drills so that we make sure things are working and we modify them based on the results of the drills. Next slide, please. The last area that I'm going to talk about, next slide, please, is the importance of collaboration. And we found that this was necessary, absolutely vital for us during the pandemic period. In fact, for all pandemics, these are collaborations between multiple agencies at different levels from the people, public, and private sectors. Obviously, during SARS, we leveraged on existing clinical collaborations to keep us up to date with information and about how to look after patients. But we also found an opportunity internally to collaborate within our healthcare system to share manpower, resources, as well as knowledge. Because as you recall, I said, one hospital was converted to an isolation facility, and we actually had to draw on other hospitals for resources and things like ICU ventilators. Our laboratories also, I think, had to collaborate together in all the different hospitals to make sure that we had common test protocols and we had the ability to have new test kits and quality control processes. Within the community was where I think our biggest opportunity lay. The collaborations that we had to put up in the community involved, getting multiple agencies together so that we could coordinate public information and education. Among the medical practitioners, we formed the primary care practitioners into a public health primary care network. We had more than 8,000 persons who were placed under quarantine during that 3-month period. And we needed to have surveillance for these individuals who are under quarantine. And we also were required to provide social and financial support for people. So, we mobilized community networks, social networks, and non-NGO groups to provide things like food and entertainment, and care packages for people under quarantine. These community measures were really, really important because it helped people who were feeling disempowered and useless to contribute a little bit towards that national effort. It also extended within the ASEAN regional bloc. So between the ASEAN countries, there were also meetings to standardize measures and to standardize emergency communications. And the last area is the area of epidemiology, research, and innovations. Within the e-government framework, many agencies were brought together, including private players, to help us to organize and obtain information and collect data for contact tracing, to create registries for patients with infections, and for case management systems. We tapped on many industry alliances for solutions that we needed, and some of these solutions we needed on a very, very fast turnaround time. So I think one of the things that I talked about earlier was this thermal imaging, and that was really a collaboration between our defense, our armed forces, and industry to come up to adapt and modify infrared thermal imaging technology so that we could screen large numbers of travelers. We also had a need for remote monitoring and video conferencing. Now, video conferencing sounds like, it's so simple, but 17 years ago, it was a difficult thing, and we really needed the collaboration of multiple players to be able to set up video conferencing even for patients. Okay. And finally, in the area of research, we had leveraged on existing research networks and brought additional players on so that we could kickstart, the production of test kits, vaccines, as well as research into areas such as predictive modeling. So I think, society and the whole country had a significant change after SARS, and we continue to leverage on a lot of these changes, especially in the collaborative space. And that has helped us, I think, to strengthen our existing networks, to create new areas and opportunities for collaboration. So that brings me to the end of my sharing. Thank you again for the opportunity. It's been 4.5 months since the start of COVID. Many of the protocols that we have put in place are still, functioning. We've increased our testing capacity from 4,000 to 8,000 to 14,000 tests a day through a lot of these collaborative networks. And we have been able to, I think, manage this lockdown period. We're not calling this a lockdown, but we're calling it a circuit breaker. We've managed to manage this lockdown period relatively well, and we're starting to come out from lockdown. And I'm glad that our healthcare system hasn't been overwhelmed. During SARS, we had reached a stage sometime in the beginning of April where we thought the ICU capacity had reached maximum. And we were starting to think about bringing another hospital online as an isolation facility. But thankfully, that never happened because the numbers went down. So this time around, I think we've managed it much, much better by controlling the number of cases that are infected. Although we did have a black swan, and that was the foreign worker dormitories, but every epidemic and every pandemic actually has its lessons. Okay. So thank you all very much.